December 4th, 5th. I'm not even sure what day it is. I know it's December, and if you work in dental, it's a crazy time of the year. So we're super excited to have everybody here. Welcome to our second webinar we've done this month on insurance, because insurance is everyone's favorite topic, especially this time of the year. And I'm super excited to be here with Teresa Duncan from Odyssey Management. If you don't know me, my name is Laura Hatch, and I am the founder and owner of Front Office Rocks. And I've asked Teresa to join us today because we're going to talk about top 5 insurance questions. So Teresa, thank you for joining us today on our webinar.
I appreciate you having me on. I love what you're doing, and I love that you're getting out and telling people the stuff they need to do now, like what they need to know now. So this is really timely because insurance is all getting ready to turn over next year. So good job.
Exactly. Thank you. So I have to tell everybody a little story. I've started Front Office Rocks kind of about 5 years ago. I started at an organization called ADOM, which is the American Association of Dental Office Management. I went and saw some amazing speakers there, and Teresa Duncan was one of the first speakers that I saw. I don't like anything about insurance. I hate dental codes. I hate dealing with insurance. I like customer service. I like systems. I like communication. And I went to listen to Teresa and thought, this is going to be so boring. But it wasn't. It was amazing. And she is my go-to guru person when it comes to insurance. So I started stalking her the first time I saw her speak. We've now become really good friends and have spoke together. So she's my go-to person. If anybody asks me an insurance question and it's over my head, I go to Teresa. So thank you so much for being my guru. Can you tell us a little bit about you and what you do in Odyssey Management, and then we'll get started on today's
topic. Sure. No, I didn't even know you were like stalking me. You kept it on the
stalked you. Yes.
Would have welcomed you in. You didn't have to stalk. So I've been an office manager for about 20 years, but I started out in pretty much every other position other than manager. So I cut my teeth on being an assistant, on being a receptionist, then went on to manager, and then just decided I want to be out there helping and educating. You know what that feels like. So it's been really good. I started consulting, I started speaking, and then I realized maybe the consulting is not exactly what I need to do. There's so many good consultants out there. My sweet spot is educating and getting the word out and sharing what's happening with insurance and management. And I think I found my niche. I'm super happy with what I'm doing. So I'm everywhere. If you ever need to find out what's going on with insurance, I'm pretty much everywhere. So your people can find me.
Yeah, exactly. And just so everybody knows, if you're planning on going to Yankee, Teresa and I are actually going to be speaking together about, cross-training assistants front and back and how the front and back work well together. So we're excited about that. It
was kind of a happy accident, though, Laura, because it was supposed to be you and Kevin Henry. And Kevin, his daughter's turning 21. And of course, she wanted to spend it with him. And so, when he said, Teresa, do you mind speaking with Laura? I'm like, oh, that's so hard. I don't know how I'm going to do that, So it was kind of like, yeah, get out of here. We can speak together. We don't need you. Get out.
Exactly. We're going to have a lot of fun for sure. Yeah. So you mentioned that you love this insurance stuff. And you just mentioned to me earlier, I want to make sure everybody knows, we're going to put your contact information at the end. But you have a newsletter that you put out, right? And you just did a meaty one, you said, right?
Yeah, it came out yesterday. So my newsletters, I don't put them out every month because there's a lot. I try to write a lot. It just dropped yesterday, and certainly feel free to go to my website, check it out. It's on Facebook. It's linked on Facebook and LinkedIn and all of that kind of stuff. So it's easy to find. And if not, just email me and I'll send you the direct link.
Perfect. Great. I also want to do another little plug for you. And you know this, every time I speak, I give this away. This is a book that Teresa wrote, and it's called Moving Your Patients to Yes, Easy Insurance Discussions. And like I said early on when I started with Front Office Rocks, I personally don't like the insurance game. I don't like playing it. I don't like talking to patients about it. And when she wrote this book, I thought, it's going to be boring insurance stuff. This is an amazing book. This book, it ties what I do and train with what Teresa knows about insurance and how to get your patients to accept dentistry with that insurance discussion. I recommend every dental office, when I speak, I give one away, and I recommend every office have everybody on the team read this. Because, when the dentist tells the patient they need something and then they leave, they look at the dental assistant or the hygienist or somebody else on the team, not just the front office needs to understand how to have these insurance discussions. So a little plug for your book. If you haven't gotten it, how can they get a hold of the book, a copy of your book?
It's on my website, and it's also linked on my Facebook under products. So if you hit shop on my Facebook page, you can find that. But yeah, on my website, there's a direct link to it. my big caricature face pops up, so you should be able to see it.
Perfect. And if you stay with us to the end of this webinar, or if you're watching it, not watching it live, we'll have all our contact information. And since I'm plugging your book, I'll plug my book too.
Absolutely.
This is a good book for 2019, a book club for your office.
Yes, yes.
This is a step away from the drill. And I wrote this for dentists to understand what should be happening in the front office to get the front office and the doctor connected, because we understand most of our doctors don't understand how to run the front office. So that's the end of our commercials.
That's a good book, though. That's a good book. Everybody should have it. I love it because it's really high level. And I like that. It's not just your basic, you have to run a report. It's more high level than that. I love it.
Thank you. I think this is a good combination. Everybody should get this for your Christmas gifts this year.
Yes.
All right. So the way today is going to work, we just wanted to introduce ourselves. And, a lot of times we hear these webinars, you don't see the faces behind the voices. So we want to introduce ourselves this way. For those of you that are live on this webinar with us, there's a chat function that you can click onto. And somebody's already put a chat in there that says, love that book. I think they're talking about your book. So we're super excited about that.
Oh, that's Suzanne. Hi, Suzanne.
What I'm going to do is I'm going to monitor the chat while Teresa is talking today. And I will jump in with questions and stuff you have. So please put in questions along the way. If it's on the topic she's talking about, I'll jump in and make sure we get it answered. If there's something a little bit kind of off and one, just something special for your office or doesn't follow today's topics, either Teresa and I will reach out to you about that. So make sure this is active. We want to try to get as much knowledge from Teresa as possible in the time together. So Teresa, if you want to go ahead and share your screen with the PowerPoint that we have, and we'll stop the video.
Let's do that. Okay.
All right. And so what we'll do,
Laura, I'm going to count on you to let me know that it's going all right.
Yep, I will. If it's not moving or something, I'll jump in. So
okay, sounds good. So
go ahead and stop your video there too, just so that.
Oh, do you want me to do that? Yes. How do I stop it? Let's see here.
Bottom left, I think.
Stop video. There we go. How's that?
Focus.
Okay. All right. So when Laura messaged me, she said, give me your top 5 dental insurance questions. And I was like, oh my gosh, top 5. I have like a million every time I speak. And it really just kind of goes to the whole environment where just insurance is becoming more and more hard to work with. There's a lot more confusion out there. And then added to it is a constant flow of new people coming in who don't understand insurance. And so they're struggling to learn the customer service, which Laura does such a good job with. They're struggling to learn the marketing. They're struggling to learn even how to talk to patients. And then we throw on these insurance issues. And it's kind of a bad soup that's out there. And so hopefully, if you have somebody in your office that is brand new to insurance and doesn't quite understand it, what I would love for you to do is just do a full stop, give them a book to read, either my book. Honestly, I would love for you to look, get Charles Blair's Administration with Confidence. The Coding with Confidence is great, but the Administration with Confidence is a really good book to have. Get the ADA Companion Guide. Basically, there needs to be like an immersion into insurance because it's such a huge part of your office. So let's move on to the top 5 insurance questions here because
and I'm going to actually jump in on that because you and I agree on that 100%. I do some basic insurance training on my courses on Front Office Rocks. And what we have to understand is that when it comes to patient care, customer service, talking with our patients, a lot of times we get into that insurance discussion. And if you've got somebody new who's not confident, not trained, case acceptance is so important and making sure we're quoting correctly and that we're talking to patients correctly. So don't just throw a new person to the wolves. Help them out. There's enough resources out there. Like you said, Charles Blair, you, me, get the training that these new employees need because in the long run, it's going to backfire on you and your patients and your care if you're not training your employees correctly. So I 100% agree with you.
Well, and just to illustrate that point, Laura, I shared this in my, I've been sharing it lately because it happened actually at ADOM. I was giving a beginner's insurance course, which I give almost every year at ADOM. So if you need that, we're going to be there at that meeting. That's that American Association of Dental Office Management. So it was a beginning course. A couple weeks before the course, I get a question via email, and the lady says, or the girl, I should say, it's a girl, says, are you going to go over what a deductible is? And I thought, wow, this girl is in charge of collecting money and doing the finances. So I called the girl. I emailed her back and said, of course, I'll definitely go over that. But I called her because, Laura, I can't go 2 weeks like letting this person not know what a deductible is.
Right.
So I called her, we explained it. I explained it. She understood it. But her story was she was hired. It's a new dentist office. She was hired, money's not flown. So they pretty much went with somebody who's brand new with no experience. And here she is presenting treatment plans and filing claims. And she needed a lot more help than just what's a deductible, but she's on her good path now. She's learning, but yeah. And I'm sure you run into that all the time. It's kind of super scary. I think doctors just assume there's this level of knowledge out there, and that's just not true.
Yeah, so, I actually had a dentist who signed up for Front Office Rocks on a Sunday, and he live chatted with me, and he had just let go of his office manager. And this office manager was the only person in the practice who knew anything about the insurances, the code, billing. And so here he is owning a business that he didn't even understand, how the majority of it worked. So it's really important that we add the training into it. Okay, so let's get started on the hot topic of the year.
Yeah, you were saying you get this question a lot too, and I get this question a lot. So 4346 was a new code, kind of burst out onto the scene. We're getting used to it now because it's been around. But what this is basically is it's not a difficult prophy. That's the number one thing that we need to get across. So the issue with 4346, which is scaling in the presence of generalized, moderate, or severe gingival inflammation. I would like to call out the word generalized. Generalized means it's present throughout the mouth. Localized means it's in one or two areas, right? So generalized is throughout the mouth. So that's the first criteria that's got to be met. Moderate or severe inflammation is the other criteria that has to be met. And in order for you to see that, there's an evaluation that needs to be done. So you can't just spot inflammation across the room and it works. Although, Laura, as dental people, we can spot it across the room. However, we need to do an evaluation, and it has to say either moderate or severe, and it's got to be throughout the whole mouth. So the issue with this code is that there's a lot of offices out there who just kind of threw this in the mix and said, okay, well, if 4355 doesn't fit, which is debridement, then let's use 4346. If they're not quite ready for a scaling and root planing, then let's use 4346, which is not really the intent. So if you have a patient who has a lot of puffy gums, they're bleeding, but they don't have any bone loss, that means that they don't have a lot of pockets. So if they don't have a lot of bone loss and their gums are just puffy and itchy, could be that they haven't come in a while. Could be that they they started taking new medication that caused their gums to be inflamed, and that happens all the time. Could be that they're pregnant, because pregnancy does cause, in some women, gingival hyperplasia, which is basically huge puffy gums. There's a couple reasons why you would have what looks like a disease, but it's not a disease. It's just puffiness. So and inflammation. So this is not a code that you can pretty much just throw into the system and have it apply across the board. It's very specific. Now, the issue I hear all the time is that, okay, they're not paying it as a 4346. And what that means is it's a little bit different than a prophy. It's not quite a perio maintenance. It's not quite on the same level as a 4355. When I charge a 4346, it's not paid at the fee that I assess. It's downgraded to a 1110. So there are certain plans that will pay a 4346 at 100%. Some plans will pay for it at 80% after deductible. What I see most often, though, is that it's downgraded to 1110 and paid at the percent, the preventive percent. That's pretty much what we can expect for now. When we have a new code, there's just not enough data for the insurance companies to figure out what to do with that code. So it's going to be like this for a while, and until some studies and data come across. So my advice to you is to assume that 4346 is going to be downgraded to a 1110. And if it's not, then good, surprise, cherry on top. But if you have a 4346 and it gets downgraded to a 1110, according to your PPO contract, if there is a fee for 4346, that's the fee you should be allowed to charge. Just because it's downgraded doesn't mean that you write it off. It's very similar. This is the exact same situation as a composite being downgraded to a silver filling. So, Laura, I gave your readers the actual complete description of the code from the code book and I highlighted what I think has to be in the documentation for it to work. If you feel strongly that the 4346 should be paid at a higher level, you can always appeal, but I can just tell you in my experience, it has not been successful to appeal it, but they will let you at least charge up to the 4346. Is this around the same lines as what you get, the questions that you get in your courses?
Yeah, for sure. And I actually have a couple of questions for you just for, I mean, I'm, like I said, this is not my forte, so I'm just going to be a new user like some of these people listening, I'm sure.
Sure.
How often does the ADA come up with new codes? Because I remember this being the big talk last year. Oh, we're going to be able to get paid more and it's a new code. How often? And then I've noticed that ADA comes up with one thing, but that doesn't mean the insurances keep up with it or pay on it. Can you talk about that?
Yeah, and that's a really good question, actually, because what a lot of people don't understand is that just because we have a new code doesn't mean that they're going to be paid for it. And so I always push that out. And, every year I give a coding update webinar. And I can send your readers the link. I think it's January 7th or 8th. And it's basically just, we're going to go over the new codes. And I always say in this webinar, you will not necessarily get paid just because there's a new code. For example, we have new codes for next year we're going to have for copying records. I mean, who's going to pay for that? Nobody's going to pay for that. But we have a code for it. So the ADA is comprised, the Code Maintenance Committee is comprised of a couple different organizations, which are the specialty organizations, Hospital Association, Center for Medicare Services, CMS, the government, that's the government, the Deltas, and a lot of the other insurance companies. So there's a lot of players at the table. So they meet every year. You can submit a request for a new code. If you go to the CDT page on the ADA's website, you'll see it. You can request a new code, but you have to be really good with the documentation on it. So then they sit around and they debate it and they decide whether or not it's going to go through. 4346 is a great code because it does fill a gap. However, I know it's been hailed as like the second coming of coding, and it's not that. So
Right.
it's a useful code, but it's definitely not the most fun code to deal with because of the downgrade.
So speaking of that now, talking about implementing it conversationally with patients I'm sure the hygienists love this code. Doctors I saw everybody talking about it and it does fill a gap. But then we also have to make sure we have that conversation with the patient. So do you have recommendations of like how we explain this, saying, this is why? Is it kind of like, because what I get frustrated with is when we tell a patient they need to have, a perio maintenance, and then the insurance says, no, do it as a pro fee. And now we're arguing with the insurance about what we actually did versus, what they're telling us to code with. So do you have any recommendations about that?
Sure. Yeah. And same thing with 4910, you can tweak it. You can tweak the 4910 conversation, but let's talk about 4346. So it all starts clinically. The doctor will say, I hate to tell you this, Mrs. Jones, but you've got a lot of inflammation, and I really want to take care of that first before we move forward with figuring out how your gums, how healthy your gums are, and if we need to address that with other work. What we need to do today is a different code than what we normally would bill for cleaning. So I don't want to bore you with all of the details on that, but I know you plan to come in here today and have a cleaning done, but I need to do a different procedure because of the inflammation. So I'm not saying, I feel like I'm not saying here's what we're going to do. It's going to cost you a lot more. I'm really tying it back to the condition I see in the mouth, because that's hard to argue with, right? I mean, the person's got inflammation. So, based on what I see going on in your mouth, I wish that I could do what we had scheduled today, but I need to zig a little bit because what you have calls for something different. Jean up front will talk to you about the fact that, it may not be covered the same as a regular cleaning appointment, a normal cleaning appointment, but she'll work out the numbers with you on that. It's not going to be a huge amount out of pocket. And in my experience, some insurance companies even cover it completely. So I always, if a doctor or a clinical team member is going to talk about insurance, I always want them to say it shouldn't be a huge out of pocket. They will make sure up front, but I do believe you need this procedure. So I'm never going to say, though, that everything is covered 100%. That's the number one takeaway from that.
Right, exactly. And that's where I think it's important that the clinical staff is comfortable with having those discussions, because if they avoid it, then a patient just assumes they're getting a pro fee, and then they're upset later at the front office because we didn't have that discussion.
Yeah.
Two questions about this. Once you have a 4346, if they downgrade, can you do a pro fee after, or no? Is this a 4346?
Oh, yeah. You can do whatever you want to. You can do a pro fee right afterwards. In many cases, that's the appropriate code, right, because the inflammation's gone down, and now you can actually do a full pro fee. But because of the patient's benefit limitation, if it's every 6 months, then obviously that next one's going to be out of pocket. If it's 2 per year, then you're going to have to make sure that the next one that you do 6 months down the road is going to be collected from the patient. So yes, so you can do whatever you want to. It's just the fact that you've got to make sure the patient knows the benefit limitations exist, and it's an, oh, by the way, your insurance is not going to, blah, blah, blah. I don't want you to put the fear of God in them. Just basically, let's see how your benefits work with it. But we plan to do this.
Okay. And it's not in the past I've heard once a 4910 or once a perio maintenance, always a perio maintenance. That's not the case with 4346. This can be for one time only and then never again, right?
Well, one time only. And I don't know, maybe 3 years from now, they've got another set of medications that's doing it again, or they're pregnant again. But in your situation, what you're talking about, like this one visit for an evaluation, yeah, it should be just a one time. I can't imagine that they're going to come back in and need it. You're going to want to move them at some point to some sort of surgical intervention.
Yeah, got it. Okay, wonderful. That's great.
Okay.
I think that helps a lot. Hey, one last thing, I guess. Do you see the insurance companies moving towards paying for this? Like, do they keep up with the new codes over time once they see enough codes getting submitted?
Oh, for sure. Yeah, we saw that with 4381, which is the Arrestin. It's not Arrestin, but it's the antimicrobial. We saw that a lot. So a lot of plans have picked up paying on that. A lot of plans picking up on paying for adult fluoride, whereas before it was not covered. So yeah, they take a look at utilization. They take a look at what the employers want. That's really what's first and foremost. Unfortunately, what I have seen with this code and hearing from offices, there's not a lot of pushback on this code, which is going to affect how the insurance companies decide whether or not they're going to pay for it. But let's go back even further. I think there's not a lot of pushback on this code because I still hear a lot of offices that don't use this code. They don't want to use this code, or they don't even know about this code.
Yep. Okay. Yeah. Okay. The more we use it, the more we push, the higher chance we got. All right, great. So I think that's a great explanation for that. What's our next top 5?
Oh boy. Radiographs. So, and I kind of just was in a goofy mood, bite wings, FMX, and CBCT, oh my, because those are the questions that I typically hear all the time. There are so many restrictions now on radiographs. And I'm saying radiographs, I know when we talk to our patients, we say x-rays a lot, but I just want to share, I got dinged one time by a doctor because he said, they're not x-rays, they're radiographs. X-rays are the beams that are made, that we use to make the radiographs. And he was very, very set on that. So I almost feel like I got scolded that day. So I say radiographs now.
That's funny because I used to say the word staff when I talk about the team. And then somebody said staff is an infection team. And I was like, oh, and so now every time I see the word staff, I'm like, change it to team.
I know, same here. I'm the same way. But being called out on that in the middle of a class was like, oh, and I was a young speaker, I was like, oh my gosh, like melting into the floor. But anyways, so radiographs. What we see a lot now are bite wings being restricted to once every 24 months, which is not, it used to be once every year. We're seeing a lot of once every 24 months. FMXs, of course, we've noticed have been going up to 5 years, 60 months. That has been around for a while. I don't see a lot of 3 years. I keep hearing also from from insurance coordinators that plans that were FMX 3 years for years now all of a sudden are FMX for 5 years. So we're starting to see that. CBCT, I just want to address, there's always, these Facebook groups are great and I love that we share, but sometimes there's information on these groups that isn't quite accurate. The CBCTs, I hear people put in there, do CBCTs get covered? And there's always a string of no. And that's not accurate. There are definitely some payers who pay CBCT, and I'm not talking medical. MetLife has been paying CBCT films for a long time. So, I used to do implant coordination. I used to teach implant coordination for the ICOI. And even back then, they were paying CBCTs about 10 years ago. So there are benefits for CBCT. Now, do I see that increasing? No, I don't. And in fact, I just attended an insurance industry class where they said the rate of CBCT is rising, but the payment has been steady for a while. So until we hear kind of an uproar from employers or until it becomes known as the standard of care, which I don't see that happening for regular visits, then that's still going to be a fringe benefit, but it's definitely reimbursable. So I don't throw the baby out with the bathwater there. You mentioned a couple things here that aren't specifically to coding, but I just wanted to point out, one of them is you mentioned be careful in groups. And I follow a ton of social media groups there's so many of them now, there's almost too many. Yes.
Be careful who you listen to, especially when it comes to coding, when it comes to patient. I get a lot of the questions about, patient's mad, how do we handle this balance? And some of the people and some of the doctors out there, it's like, they're not really necessarily I don't know. I just be careful who you listen to, especially when it comes to coding. Make sure you listen to somebody like Charles Blair or like you, Teresa, or people who know what they're talking about.
Yeah, it's a little scary. I mean, some of the, and honestly, if I were to go in and correct everyone or gently correct everyone, I would do nothing, because honestly, that's how much information is out there that's not exactly correct. And I mean, God bless the people wanting to help. I get that, and I appreciate that, but Yeah. All right. So let's talk about, what do you say to a patient who, wants to just do what insurance says, but your office would prefer that a full set of radiographs is taken every 3 years because that's what your doctor thinks is appropriate. This patient meets that criteria. They've got a mouthful of, old fillings, old crowns, or whatever. Waiting every 5 years is tough on this type of adult situation. So, every 3 years is really what your doctor wants. And in some cases, we have some patients who have just rampant issues. Maybe it's 2 years. So change it as you need to. Here's some verbiage for you. Your plan provides benefits for a full set every 5 years. But what we found is that many patients need this more often than that. So 5 years is great for patients who've never had a cavity or they're young, but in your situation, we've worked with you before, you've had cavities, you've had crowns, and I don't think you want to wait for us to catch it down the road. So I'd like to catch it sooner. My preference is 3 years. So, and what I just did was I acknowledged the objection, but I explained why it was specific to them. And that is really hard to argue with, because honestly, what patient is going to sit there and say, we'll just deal with it when we get to it. So if somebody definitely has an issue with payment, maybe they're on a fixed income, they absolutely cannot afford it, then I don't think that we need to be so harsh on them. People have their reasons. But for the most part, you have patients who just see that it's covered every 5 years. And in their mind, that's all they can do. They don't think past the limitation. They just assume that must be the rule.
Right.
So, and here's another follow-up to this is, although your insurance is not going to chip in for these images of your back teeth, I'm talking about bite wings, we need to see them to see what's going on between the teeth. And I've watched doctors, really nail this conversation where they basically put their fists together. And they, like you're, kind of like a boxer, you put your fists together and then you ask a patient, can you see in between my fists? Because that's really the size of the teeth when I'm looking in the mouth. I can't see in between there without those x-rays. And patients, they don't realize how thick teeth are, honestly. So show them that. And I think x-rays are great to show them on the screen, but when was the last time any of you pulled out like one of those models, the 3D models of the tooth, so that they can see just how thick those are? We can't see it visually. So don't be afraid of the limitations with radiographs, but I will say from the ground level, this is becoming a huge pain point, because these are the small little bits that we have to send statements for. We have to chase patients for this. So yeah.
And a lot of this is a philosophy change in the practice. So if you're running a practice based off of only what the insurance will do, then it's gonna be a lot harder. But if you're running a practice and your doctor has the philosophy of we do what's best for the patient, then you get books like, Teresa's book and my information to help you with the verbal skills. Because Absolutely. Like you said, the way you voiced it, Teresa, was perfect. And somebody asked about getting a copy of this. This is gonna be recorded, this webinar. It'll be on YouTube. You guys can refer back to it later. And of course, I'm sure you have all of this in your books and more things that they need. So we have a couple questions on documentation. Is there particular notation to submit for a CBCT, or do you document why patients are refusing x-rays? Do you have thoughts on that type stuff?
Yeah, so there's two questions there. So that the CBCT, there needs to be a diagnosis for why, and this is actually for all radiographs, there needs to be a diagnosis for why you need the CBCT. And it could be because your implant, you're doing some planning, or you need to see the structures because of, whatever surgery you're planning on doing. So always have a diagnosis and a reason. And then you have to make sure you got the right code. Is it a 2D image, 3D image? Is it reconstructed? Is it a limited field? Is it a, big field? So you have to make sure that that's all. And I apologize. There was something weird going on with my dog. Did you hear that? That was awful. So,
yeah.
I'm so sorry.
Griffin, her dog, is in the background learning about coding too.
Griffin's a very good insurance coordinator by now. He's heard enough webinars. So make sure that you have the reasons, and then also who read it, because who reads it is different than who takes it a lot of times. So always make sure that you have the person who read it. and then what you found off of it. A lot of times we don't even write what our findings are. So have all of that documented. And then the last question, what was it again? Because that was a different question.
If a patient refuses x-rays.
Yes. Okay. Yeah. So if a patient refuses x-rays, so there's 2 reasons a patient refuses x-rays. One is that they have maybe read something and they're really nervous about it. Or 2, they actually are very scared of the radiation because maybe they're going through chemotherapy or something like that. Section 2, I totally get, I understand. Section 1 is really all about educating them on that. So if they come in and they don't want x-rays taken, may I ask what is the reason? And if they give you one of those reasons where they saw, The View talking about it or whatever, actually radiation is very low. You actually get more radiation walking around outside than you do with our radiographs, and we get our machines calibrated. It's very low. We have the collar. You can kind of tell them all about that. And then what I always say is it's really, really hard for the doctor to really get a good look at everything without those radiographs. So honestly, he or she may feel that they can't do a good job with your evaluation today without those radiographs. We may have to do an incomplete evaluation, which means we can't give you a true picture of what's going on in your mouth. And because honestly, I'm not scaring them. That's the consequence. It's true. That's absolutely the consequence. So I have worked with 2 types of doctors. One type of doctor will give them 1 free pass and just, beg them basically to take bite wings. And then I have worked with other doctors that just say, I'm sorry, maybe you need to find a different office. I just can't do that. And when the patient sees how dedicated you are to that, maybe they change their mind. As I age, I am now firmly in camp number 2. If a patient comes in and basically asks to tie your doctor's hands in doing a diagnosis, basically asking you to do a diagnosis without an explorer and a scaler, what am I doing here? So I actually would not even bring that patient in as a patient of record.
I agree with that. And I actually talk about that in my book too, because your doctor needs to be on the same page and helps put the line in the sand. So in order for everybody, we have questions coming in, but some are a little bit more specific about different things. So I want to make sure everybody listening to this live, we will make sure these questions get to Teresa. She'll make sure to answer them for you specifically. But since we have 5 things to get over, we're halfway through. I'm going to let Teresa get going on number 3.
And what I'll do too is I'll probably do a video answering all of the questions, and we can both share that on our site. So if you have great. Okay, so help, my buildups never get paid. I know. So this is what I hear all the time. Buildups are getting harder and harder to get paid. I'm giving you here the criteria that you're going to need in your doctor's notes to get paid. That doesn't mean that your doctor makes stuff up, obviously. But the criteria for buildups is really, Dr. Gordon Christensen is so well respected. He basically came up with this, and then a lot of the plans looked at it and said, okay, that's our criteria. So run this by your doctor and see if your doctor can change the notes to incorporate this information if that's present. Most of the time, your doctor is fulfilling these requirements. They're just not putting it in the notes. Now, the reason why I want it in the notes is that you, insurance coordinator, can then grab it and put it into your narrative. Or if you're an insurance coordinator that just does screenshots of the clinical record, and that's what you send with your narrative, at least it's sitting right in there in your narrative. So how many millimeters were removed? That's super important. Any recurrent decay that was removed, that's super important. Periapical and bite wing is definitely needed. If you've got an FMX, better, but bite wing is really what I can use. Intraoral images are just so needed right now, and I'll tell you why. There's a couple insurance companies who have changed their policy now, and if you're in network, this is a big pain because you're pretty much forced to do this. They have changed their policy now to require an intraoral image prior to the buildup being placed. So the doctor has drilled out all the decay. Before they prep for the buildup, stop, take an intraoral image. After the buildup is placed, stop, take a picture of the buildup that is actually in place before the prep. Now, there's 2 questions I get for this. Number 1 is why? What the heck? The big answer, honestly, is fraud. So crown buildups have been easily claimed and pretty much really hard to prove that they're actually there because, you have to destroy a crown to show that it's there. Second is there are many doctors out there who are billing crown buildups with every crown. And so it's a very highly fraudulent code. So a couple tips on buildups. What I would love for you to do is build for the buildup. If it gets denied, hold on to that because you've got a document control number there, the claim ID number, same thing, document control number or claim ID number. I want you to either call or write an appeal with the date that the crown was ceded. And a lot of times your insurance companies will pay for it once the crown is ceded. So what a lot of offices do, which I'm not, and this isn't even one of the questions, but I'll just bring it up here. What a lot of offices do is they hold the buildup and the crown together and bill it all on the seat date, which honestly just doesn't make a lot of sense to me. I bill for most of my buildups and crowns on the prep date, unless I know for sure that the seat date is what they're going to require. Big example is Delta. So a lot of you are sending in the buildup on the prep date and then holding onto the crown on the seat date, and then it just becomes kind of a big mess according to the insurance company. So they have policies written where the buildup is allowed, but the crown has to have been done. So if there is no seat date submitted with the buildup, then it's going to look like the crown wasn't done. And it's not necessarily somebody sitting there, coming up with little crazy ways to not pay you. This is written into their processing policies where not even anybody looks at it. It's just kind of an automatic denial in many cases because there's a buildup being submitted with no seat date. So in your narratives, if there is a seat date already, go ahead and put in that seat date. If you haven't seated the crown, I would submit the buildup. If it comes back denied, then you're going to resubmit with the seat date. Or you can hold on to both and submit them both with the seat date and make sure your narrative says buildup and crown performed, buildup was done on this date, seat date is this date. So buildups are very, very confusing. And I definitely can tell, I haven't even looked at the questions, but I can just, being a Swami here, I can tell that there are more questions on this because this can take up a good half hour of a lecture for sure.
It's funny you say that. There's no questions at this point. I think maybe you've gotten to the point where you know the questions that people are going to ask. And so
that's excellent.
Yeah.
Oh, good. But if you do have a question, don't be afraid to put it in there because I definitely want to make sure you get this straight because buildups are expensive. It's a hard write-off to take. And I don't want you to have to do that.
I think that intro images are a huge thing no matter what. I mean, I recommend taking pictures all the time along the way because it's better to have it than not. You can't go back.
It's tough though because there's a lot of, and I agree with you, it's tough though because there's a lot of doctors who have had a clinical flow going for years. They've been doing the same thing for years. They're doing it well. And now all of a sudden, because of documentation, they've got to stop their flow and introduce, an intraoral image. And it's tough, but if this is what needs to be done for you to get paid, I want you to get paid. So, a little bit of pain.
We actually train our dental assistants for that. And so for each procedure that we want certain things, the insurance coordinators, we have like a check sheet for the assistants so that they stop the doctor along the way because they're a little bit more in tune with what we need, especially if they're somewhat cross-trained versus the dentist who's been doing it the same way. So have the conversation with other people on the team too, not just the doctor.
Excellent. Okay, so here's a common complaint that, obviously, Laura, you've got this down in your office, but I think other offices, we hear it all the time. Clinical doesn't give me what I need. So I wanted to just give you a couple of tips, and I'm not going to tell you what you need. Obviously, you know what you need from clinical. What I want to give you tips on is how do you talk to your clinical team about it so it doesn't sound like you're just a broken record. I know from being a manager for years that, definitely there were some assistants who just tuned me out. I get it. Sometimes I'm saying the same thing. So I always, I want you to think about it in a different way. I'm not going to stop back there and say, I could have had this paid if I'd have just had that x-ray that I told you I've been wanting, for years. What I'm going to do is kind of attack this a little bit more proactively. I'm going to insist during regular team meetings that we go over insurance changes. There may not be a lot of insurance changes, but you know what? There's probably going to be a lot of insurance changes. And part of any regular team meeting, your monthly meeting, I guarantee you that some of your team members are going to have questions about insurance or they heard something funky and they want to run it by you. But, we're busy all day and they may not remember it. I'm not saying have an insurance focused meeting. What I'm saying is maybe make an insurance quarter, like 15 minutes of insurance. Any questions on it? Here's what I'm seeing. And during that time, you're going to reinforce. So this is a regular reinforcement. This isn't a ad hoc where something goes wrong and you jump up from your chair and you make sure you write a memo and you post-it notes everywhere. That's managing. That's reactionary managing, right? This is us being proactive. So in my meeting, I'm going to say, insurance changes a lot. I want to give you regular updates on documentation requirements and go over it again. Don't make it a lecture, but just say, I've noticed that with Bite Wings or with Buildups, I'm having trouble getting them paid. So if you guys could keep up taking radiographs and taking intraoral images, that would really help. Example is this one, and bring it up. When a doctor sees a patient's name and the actual work wasn't reimbursed, or you're still struggling to get reimbursed. So what you've just done is put a face on a problem. So anytime I've been in a meeting and been, listening in when I did full service consulting, I would listen in. Once the doctor heard that it was a patient, and they would stop and because they remember they did all the work, and now all of a sudden they're going to want to help you get that paid, and it's going to stick with them. A lot of times we at the front kind of speak in generalities like, oh, I'm having a hard time getting this paid. I'm having a hard time getting this paid. Try using a patient's name and see if that kind of brings the point home a little bit. It's a little trick there. Another point of conversation is saying, if we're not able to get paid, then patients become disappointed. Now, what I mean by that is if we're not able to get paid, we're not going to get paid. We're not going to get bonuses and salaries and all that kind of stuff. So that's really what I'm saying. But what I need the clinical team members to hear is that this directly affects our patient care. Anytime as a manager, and this is really management information here, anytime as a manager, I needed to have a correction with my team, I never made it personal. I never said, Kim, you never did this, or Jean, you never did this. I always said, when this wasn't done, it affected how the patients were treated. Patients weren't able to get the services that they needed because they were waiting for this, and this. Patients become disappointed. So I always bring it back to the patients, because really that is what it's all about. So try to tweak your language on that, because clinical, you need clinical. So it doesn't do anyone any good to butt heads with clinical. And then doctor support is essential. So if you have a doctor who's just not supporting you on all of this, it might be worth it to have a private come to Jesus meeting with your doctor and let them know, not saying you don't ever support me. That's not what I'm saying. I'm saying it's really hard to get what I need. I would appreciate it if you gave me more support, or I would appreciate it if you reiterated what I was saying. There's all sorts of ways to go about it, but it is frustrating when you get a claim denied and you don't get what you want with the claim. But again, try not to be reactionary. Let's try to be proactive about it.
And that's really great advice. I actually have a couple to add to that, because I love this whole thing between the front and the back and working together, I think is key. One is in the huddles in the morning. That's a great time to remind the doctor, the assistant, make sure you get an image of this. Make sure you get an x-ray, and they can jot it down. I mean, when we're in the huddle, that's, they might not be thinking about insurance as much as we do, but when in the morning we say, make sure we need this one thing, that's a good time to remind them. The other thing is to have a regular meeting with your doctor, not just when you have problems, but maybe once a week, once a month, to just sit down and talk about insurance.
Absolutely.
Patient issues, patients upset about balances, patients that aren't doing treatment, like having a real conversation, because many times our doctors just assume patients accept treatment, insurance pays, they're good to go. And if they actually see that things aren't being paid or patients aren't doing the treatment, that will, and like you said, put a name to it. I love that. I think that's great. And then lastly, just an addition that's coming from Back Office Rocks, we're actually adding clinical training to the back office, or to Front Office Rocks. It's Back Office Rocks. It's not clinical training in the sense of how to assist, but it's training like how the front can work with the back better, how we can offer better customer service. And one of the videos I'm doing is how important it is to understand what we need for insurance, so that the assistants and the hygienists can hear from an outside perspective how important it is, for care that we get this information. So reach out to resources like Teresa and myself to help you if you're not getting what you need in your practice.
Yeah, a very interesting trend that I'm seeing is assistants are becoming insurance coordinators. And I think that's honestly one of the best career paths for them, because having clinical knowledge, I was a good insurance coordinator because I had good clinical background.
Yeah.
So that makes a huge difference.
Two of our best schedulers in our practice were our doctor schedulers were assistants that moved up because they know what the doctor, how much time they need. They knew what needed to happen and they understood the flow of the back. So I agree to have a cross-trained is a great thing to have.
Mm-hmm. All right, so this is the last one. This is usually like an hour network or hour class,
Right.
and I gave a whole class at last ADOM. The more advanced level class was participation and how to evaluate it. And you were in the back of the class. I appreciated you stopping in, but it was basically we ran a whole bunch of numbers. We took a look at it. So I'm going to give you the quick and dirty answers to the most common questions I get about this, and I there's probably 3 emails a day I get on these with these questions. So should I get out of network? And my answer is it depends. I mean, it has to be. You can't say yes or no. It has to be. It depends. So I always ask a couple things, and and this is rhetorically. I need you to go and look at the numbers, and I need you to make the decisions. But who's your biggest carrier? That makes it. It's usually Delta, but let's just take Delta out of the equation. Who's your biggest carrier other than Delta? How much of your revenue would you lose if you got out of that network? And the answer to this is not as much as you think. A lot of people think because it's, say, 30% of your practice, you're going to lose 30% of your practice. That's not the case. Yes, you're going to lose patients, but there's going to be a lot of patients that stay. And then if you really have your act together, your customer service together, those patients are going to come back. So, and people go in and out of plans all the time. So it's not a death sentence, but you do need to know because you have to make arrangements for possible loss of income. And there are going to be some tough times. Which carrier could you chop off? I always look at, when I run my numbers, I always look at who is my least profitable carrier. So I have to know my procedure codes, right? So my top 20 or 30 procedure codes, I'm going to run them. I'm going to see what my top procedures are. And then I'm going to take a look at what did my insurance company pay for those top procedures and compared to what other carriers paid. Least profitable is not always the one that stands out to you. You may be thinking that the most time consuming is your worst carrier. So let's just Acme Insurance. Acme Insurance, Gene up front is forever writing appeals to Acme Insurance. So you think Acme is the worst. Acme may actually pay pretty decently, but Beta Insurance over here is the fee schedule is terrible and you have a large employer group coming in. And so you're actually losing more money on that. My point with all of this is you don't know until you look. So I always look at the numbers. What is the least profitable? And then I always do an emotional check with my front office. What's the most time consuming? The time consuming piece is important because there is a cost to labor. So you have to think about that. If Gene is doing nothing but Acme appeals, Acme needs to go. If Gene, a third of her day is Acme appeals, well, that's probably in line with a lot of the other carriers, but you would know that by running the numbers. What's your biggest write-off percentage? It kills me, but I'm seeing write-off percentages getting closer to 50% across the board. I know a lot of offices that negotiate can get better than that, but it's getting pretty bad out there. Now, what's your biggest referral source? Now, this is something that Laura, I know you have a ton of videos on this, on how to increase referrals and talk to patients and increase your customer service. When you look at your biggest referral sources, I want you to keep in mind the 3 out of 10 rule. Your top 10 referrers are going to be full of insurance companies and patients, right? If out of the top 10, if at least 3 are not patients, you're upside down. It breaks my heart to say 3 because I would love for only 3 to be insurance companies, but I just know in today's day and age, most of your referral sources are going to be insurance companies because that's what you sign up for, right? So they should be delivering at least. That's the trade-off. They market for you and they should be sending patients to you and you give them a discount. But if you don't have any patients in your top 3, something's wrong. You're not paying attention to patients. You're not building that database, that fan base of, adoring fans that are sending you more and more patients. Then go down to the next set. So that the numbers 10 through 20. If you see any patients in there, they're referring to you. Let's do something special for those. So all of the patients that are referring to you in your top 20 referrers list, they should get something special. They should get a thank you. This is marketing 101. And I know you've got stuff on this. So, and then Laura's got a really good resource on there. You want to talk about that, Laura? You're out of network.
Because it's funny, you and I get the same questions, even though we kind of talk about different areas at the front, but I get that question all the time. So I love what Teresa's saying about evaluating the insurances. And I was in your class. It was great. You had reports out. People were looking at their numbers. They were shocked by their numbers. What I speak on, I kind of follow what you have there, but also now, how do we talk to patients? Like you said, some patients will leave and some will leave and come back. And how do we tell the patients we're getting out of network? What verbal skills? How do we train our team? You definitely want to role play with your team before you drop an insurance. So I have a resource there that's listed on the bottom. If you go to that website, we can send you getting out of network a white paper about the steps that I followed, because I used to be in one office. We were in 9 insurance plans and we dropped out of everything up to Delta Premier. So I've been through it. I know what it's like. And so I've got a white paper for anybody who wants it.
There you go. And then of course the other question that I get, and I'm starting to get this more, which is a little bit concerning. Last month or so, I've gotten this question a lot. Should I go in network? Yes. And the answer is, it depends.
Yes.
If you have to run your numbers, because if your largest carrier is one you want to go in network with, then that's not a smart move, because yes, what you're doing basically is giving a huge cut right off the top. You want to take a look at your employers, run your employer list, who are your biggest employers in your practice, and then find out who the biggest employers are in your area. And I was just talking to somebody yesterday about this. If you have, for example, Boeing is in your area, you can Google Boeing Dental 2018 PDF. And if you Google, again, I'll say that. So Boeing, name a company, dental plan 2018 PDF. PDF is, of course, the form that's going to pop up. A lot of times, the large employer groups, those are out there. Those are out there for you to read. So you can do it. That's my little sneak tip there. So you can find out who the big people are in your area. And also the Chamber of Commerce can tell you who the big employer groups are in your area. Don't just go signing up because you hear you might get a good fee schedule or the doctor down the street started accepting something. Making a reactionary decision on participation is probably the worst thing you can do with this environment. It's so critical to your revenue to make a good, thought out, logical decision.
For sure. I agree with that 100%. And there are companies out there, I'm sure you refer to some, I refer to some who can help you. Mm-hmm. Do your homework. I actually it was a sad story. I met a dentist who decided he needed to go in network, and he went in network with his biggest insurance plan, and he's now losing. I think he said he wrote off, 40% more than he did the year before. And it was the worst decision he ever made. And he's looking to sell his practice now. So this is
sad.
This is not. Plus, especially now, and maybe you can speak to this for a minute or two. It
Sure.
seems like more and more groups are like umbrella organizations for different insurance plans, where you belong to one, but now you're in a network of insurances, and you don't really know that if you don't do your homework ahead of time.
Mm-hmm.
Did you find that's growing more and more? It seems.
Oh yeah, that's actually what we're going to be with. That's what we're going to be dealing with in the future. Is you're going to sign up. It's actually going to simplify. I wish this had come around about 5 years ago. It would be nice to sign with one and be part of many. The problem became people were signing up with one and thinking they were with one. So yes, there's a lot of offices now that when they are signing up, they are aware that it's an umbrella plan, a lease network. And that's actually, I think that's okay, because you can get a pretty decent fee. There's some that are the pits and some that are really good. And again, this is really important. If you go on Facebook and you ask what are good networks to be in, and people give you all their information, it's regional, people. It's not, who gets a good one from Geehaw over here is not going to get it from them on this side on this coast. So it cannot be these blanket answers, these generalized answers that people give out are really just do your due diligence. Call the dental society, go to a dental office meeting, go to your local ADOM chapter, ask around and find out what is the going rate in your area.
And understand too that your dentists get advice many times from other dentists, and other dentists know not as much about insurance as the other ones. So yes, do your homework if you're the insurance person, and get the facts and present it to your doctor and go over the numbers. Don't just assume when they come back from a course that we need to sign up for whatever plan. So one other question I have for you, and this just came to thought for me, are we still seeing that Delta Premier is going to go away? Because I know that was a big discussion over the last year or two.
So it's funny because Delta is, I mean, in many states, Premier is going away, but I can't tell you how many Delta reps or, when I speak around the country, they'll come up to me and they'll tell me no, and that's in this state, it's not going away. Like Virginia, I always thought it was going away, and the Virginia reps, told me, they reassured me it's not going away. So I get a lot of reassurances that it's not going away, but I also hear from the ground that, it's getting tougher and tougher to get a Premier network. So again, this is going to be regional. I can't make a prediction. I've actually been reached out to by people who have instructed me that they are definitely not getting rid. And this is not just reps. I mean, people in Delta. So I don't think I can say as a blanket rule that it's going to be gone, but I think it's going to be harder and harder to get that Premier level.
Yeah. And so this is where you and I work really well together. And for anybody listening, no matter what happens with insurance, if it gets bigger, better, worse, whatever, you've got to up your customer service game. You've got to understand insurance. You got to know how to talk to patients about it. But I mean, patients are expecting more now. Even if you are in network for their insurance, they're expecting more. So not only should you balance your time with understanding insurance and write-offs and all that, but you should also balance your time in making sure that you're doing training with your team on verbal skills and customer service, because that's really what patients are looking for.
And you were absolutely right. We flew through this hour. You told me that it was going to just go like that, and it did. So real quick, and I know we'll go on to the closing slide. I have a podcast, and yes, Laura is going to be on it, and it's called Nobody Told Me That. So there's a couple different episodes I called out here that I think would be really good for your audience, the bullying and why it sucks. Our friend Kevin Henry, we talked about that, and it was a pretty laid bare episode. I was surprised by the feedback on that. So I think that that's something that is really a touchy subject out there. And if that's the situation that you're in, you might want to check that out. Non-covered services I talk about. And then Laura, this is your webinar. I'll let you wrap up, right?
I know. Well, I appreciate for those that we didn't get to your specific questions, we are going to make sure that Teresa handles those questions for you. If you didn't watch this live, if you find us on YouTube, here's our contact information. Teresa and I both are very similar in the fact that we are just out to help dental front office rock stars. We understand what you guys are up against. We were in the trenches with you, and we want to be a resource for you. So there's Teresa's contact information. There's my contact information. We both are speaking nationally around the country. We're both at Yankee together coming up in 2019. So please reach out to us. We really want to help you guys. We want to be a resource for you. Follow us on all our social media. We post stuff. Teresa, you just mentioned early on, you have your newsletter that's out there and available to them, right?
Yep.
So we're always posting stuff to help you guys, and we want to be, your resource to go to. So, Teresa, any final words for anybody listening today, or anything that you want to close up with?
Just, insurance is not something you learn once and you're done. It changes so often. So at least once a year, take an insurance update class, whether it's with me, whether it's with Roy Shelburne, or Charles Blair, just somebody. Take a class once a year at least. And then my January coding update webinar, I'll put that on my social media as well. Sign up for that so you know what's coming down the pike for next year.
And we would love to have you back, Teresa. Would you come back and do some more webinars with me?
Are you kidding me? Anytime.
Right, this would be great. So please reach out to us, make comments, let us know what you want to talk about. I'm focused on teaching the basics in the front office when it comes to insurance, and Teresa's my go-to insurance guru. So together we can be a resource for you. So let us know what you want to hear. We wish you guys all, for those listening to it live, a happy December, happy holidays. Have fun with those insurance questions. Thank you, everyone, for joining us, and we will make sure we reach out to any questions that come our way. Thank you, Teresa. Have a nice holiday.
You too.
All right. Thanks, everybody. Have a great day.